thank you. First off, I'd like to identify our team members, and if you would mind standing up. Our coach was Marcella Vittora. Huge help. We couldn't have gotten this project done without her. This is our first chance at doing this, and so we were essentially lost. And so it was good to have good coaching as we went through. Rodolfo Gutierrez, who is our community coach, excellent input. He's coveted now that I told everybody, unfortunately, that he's a statistician and actually got us back on track so that we were, in fact, part of my talk is about apples to apples versus apples to oranges. And so he was a huge help in terms of getting us online and then making some great suggestions on sustainability. So thank you. And Mai Vu is a dental assistant within Health Partners. Is a great help, again, diligent worker and a huge help for us. Again, with our group, it's fairly diverse. The other members, Jume Tang wasn't able to be here. And Roosevelt Williams, Diane Taylor, Sue Tessier, and then myself. I think I'm the token Norwegian. At any rate, one of the things that we were trying to do in terms of happy teeth was identify and increase the number of publicly insured patients to receive fluoride varnish at their appointments. It's a proven fact that it works. It's a good idea. Our group had initially gone around to the medical clinics actually and trained at the family practice clinics how to apply fluoride varnish to the children, and we've actually had great success with that. And since this was our first shot at doing a project, we were casting about to what we should do, and we thought, well, let's see how we're doing in terms of managing our public program patients and how we compare our application of fluoride to our public program patients versus our commercially insured program patients. Number one of the shocking things is that as a dental group, we were applying fluoride to our patients less often than the medical group. No problem there. And then what the other shocking part of this was that we were applying fluoride less frequently to our PMAP patients than we were to our commercially insured patients. And so I think this came as quite a wake-up call. One of the things that was obviously pointed out was that we see fluoride varnish being applied every day. We think it's being applied to everyone equally, so on and so forth. And it's not until you start to examine what's going on that you find that there are holes in the theory. So, did we meet our aims? In the long run, I'll show you the information that proves that we did actually meet our goals to improve our fluoride application. Within the group and within clinics, we piloted this with 4 clinics that had the highest PMAP or public program populations. And honestly, initially, no one likes to be pointed out that your fluoride varnish, you're not doing the job that you're supposed to be doing. And so at first, it was a little bit of a rough go, but in the end, everybody got on board, and I think that within the clinics and within the entirety of Health Partners Dental, we've actually come a long ways to make this something that will move forward. Okay, our results are very encouraging that we are able to do what we wanted to do. Unfortunately, being the first round of this, sometimes we weren't asking the right questions, sometimes we weren't measuring the right information. And so as we got better as the program evolved. Unfortunately, in this process, being dentists, we're straight line thinkers. If there's a problem, we're going to solve it, and if there's a way to solve it, we're going to do it now. And unfortunately, in this process, it muddies the water in the fact that behaviors changed as this process, as the measurements were being taken. So you'll see in the data that some of the information looks like we went backwards, but in fact, it was just due to the fact that everybody acknowledging that there was a problem started to fix the problem as we went, and it changed our measurements. So I will ask your forgiveness in the busyness of the graphs, but this is what comes in the danger of asking a dentist to make graphs. So a lot of this is the comparison between our fluoride applications to our patients. And on the left side is the commercially insured patients. On the right side is the HP Care patients, or the publicly insured patients. And as you can see, initially, and this was one of the vagaries of our process, we started measuring with whatever information we could grab. We initially measured the application of fluoride on patients for a 3-month period. We were starting in the fall. We decided, well, let's pick up three months that we can actually measure. We had information for the months of April, May, and June. We gathered that information and we found this disparity. What you're seeing here does not look like a huge disparity, and in fact it does look like we are applying fluoride like we should. What happened, and as our community advisor mentioned, is we should compare apples to apples. What the process was is we find a disparity, we go to those clinics and explain that there is a disparity and how we can fix it. Okay? So everybody would naturally get on board. And as dentists, we're all thinking, fluoride, good. And it's a very simple fix. If we're not putting fluoride on, what are we going to do? We're going to start putting fluoride everywhere. And the fact is, the disparity was actually in the original database that we ordered. We ordered April, May, June. Unfortunately, this is when most of our regular staff is on vacation. And we have temporary staff sitting in who may not be in line with everything or not be trained the same. Our graph here, we decided we better compare apples to apples. So we picked October, November, December of 2010. After we've done the training, we do October, November, December of 2011. And what we found is that when you've got consistent staff that's already on board, our statistics don't look as stark as originally. Now, within this, obviously, there were clinics that were below, because this is a total of all 4 clinics. We did have clinics that were far below average. We had clinics that were above average, and it evened out to the point where it appears like we were right at around 83% application of fluoride to our PMAP patients in the highest risk category. This still doesn't explain the fact that the medical clinics are at 89%. So we're still not doing very well. But we're as bad as we thought, okay? This is one so that we can start again apply this to apples to apples. So in the high risk category, the left side is it's the same information as on the last slide, but you're putting commercial patients next to the PMAP patients. The light blue ones are the commercial patients. The dark blue line is the publicly insured patients. And so therefore, again, we were applying fluoride at a fairly consistent basis, but again, not at a rate that would be where we'd like to be. And in fact, all the moderate risk patients should be covered. So we're not, so again, in the moderate risk area, that's where we're really falling down. Fluoride application after training, or that flipped? Yes, it did. Okay, again, it just went up slightly. Okay, so again, we're not exactly getting what results we hoped we were going to get. So again, a very busy slide. This again will show us our comparison of before and after within each group. So again, on the right-hand side, which is the more important side, our HP Care group, again, just slightly went up after training. That's the dark blue slide for the high-risk patients. In the middle column, it actually went down, but thank goodness Rodolfo was around to explain to me that it wasn't a significant drop. But again, it would be surprising that your fluoride application rate actually went down after training. Okay, the good news was, and actually we started looking at this right away. Why did our application rate drop? One of the discussions that came out of this is, should we be, as dentists, should we be applying fluoride at the exam, or should we actually be applying fluoride after we're done with our drilling and filling? The concept is, if you apply fluoride, drill it off, put in a filling, and now that fresh area of cut dentin and enamel has no fluoride applied to it, you're not helping the patient as much as you could as if you waited until after you're done with the restorations and then apply fluoride. This became rampant within the system, within the 4 clinics, is that everybody agreed, you know what, we should be applying fluoride afterwards. So what we did was we saw a drop-off in application at the time of the exam. We looked at, oh, by the way, are we going to be applying fluoride later? Did we move the fluoride treatment plan down to the last appointment? And what we found is, yes, we did. Okay, so if you take a look at this slide on the left-hand side, it's our high-risk PMAP patients. Okay, first line is when before our training, second line after the training, third line is how many patients have either had the fluoride applied, and then also those, it includes the ones that have the fluoride being applied at the end of their treatment plans. Okay, good news to announce is that for our high-risk patients, the compliance for the dental group went up to 98%, which was again in our range of what our goals were. And in the moderate risk, we went up to just under 90%. So it is working. It is. I feel that we did meet our goals. Thank goodness. Okay. With only will this be easy to sustain? The only way that we can sustain this, and I think everybody who is within Health Partners, we've seen rollouts before. And our big concern is that our rollouts, we say, you haven't been doing this, we want you to do it. We say, yes, we will. We do that procedure for the first several months, and then slowly but surely it goes away. What we, again, from the suggestion of Mr. Gutierrez, is that how do we make this sustainable by taking human error out of it? We put a note, or actually it's a little ding, in the chart, so that when we finish, it will ding and say, did you apply the fluoride? And that's, at the end of the appointment, it's an easy way to remind us so that we take the human error out of it. What will be the more of a challenge to sustain? Actually, the truth is that nobody within the dental group thought that we were missing. And to actually say, no, you know who we're missing? We're missing our PMAP patients. And no one actually believed that. And so getting us to believe that it can happen and that we should try to remedy this, I think is really important. Okay. Again, we're pushing to add on a pop-on in the electronic dental record as a reminder. The good news about this is that in Health Partners Dental Group, in our new 2012 what do you call it? Goals for the 2012 health goals. Spreading EBAN, the results of our study here are actually in our 2012 goals across Health Partners Dental. So I think we've had good success there. We've had good communication with administration to actually push forward our goals. Okay? And then if we can fund the initiative for the changes in electronic dental record, I think this will be a fairly simple way to make sure that it's sustainable and it takes that human error out of it.